Hello, welcome to today's lecture. It's about infections and other issues that may affect an older adult. This is for the fourth year nursing students. The outline we will be covering is to assess the aspect of infection that may affect an older adult, identify nursing intervention to reduce infection and skin integrity. Finally, we will identify the other issues that may affect an older adult. There are common infections that may affect an older adult, which is the bacterial pneumonia and flu, skin infections, the gastrointestinal infections, and the UTI, the urinary tract infection. One of the most common type of infection, it is institutionally acquired infections. These infections that older adults commonly acquired in hospital or long-term care settings, like MRSA and also the ventricular associated pneumonia or the pressure ulcer infections. Then we have the infections of the respiratory tract, which include both upper and lower respiratory tract infections. This include pneumonia, which may be bacterial, viral, or aspiration related, or influenza or bronchitis, and also the COVID-19, especially with atypical symptoms like confusion or fatigues. Also, we have urinary tract infections, which is common and often present with atypical signs in older adults, like confusion or delirium instead of fever, or new incontinence, and fatigue or decreased appetites, and often caused by E. coli. Also, we have risk factors for the UTI, which is the catheter use, poor hydration, incomplete bladder emptying. The other issues we'll be covering during this lecture, which is ethical dilemmas, rehabilitation of the older adult client, abuse or neglect, palliative care. Also, we'll be covering the euthanasia and physical assisted suicide and don't resuscitate terms, and also medication, communication, and sleep and rest issues. At the beginning, the ethical dilemmas, we have four basic principles. The first one is the respect for patient autonomy, which is defined as allowing or enabling patients to make their own decisions about which healthcare interventions they will or will not receive, based on their personal values and beliefs and preferences. For example, we have 80 years old patient with early stage dementia who decided not to pursue aggressive chemotherapy for newly diagnosed cancer. As a nurse, you have to respect their decision, even if the family members disagree, and ensure the care team support the palliative care instead. The second one is the beneficence, which is actively doing good for others. In healthcare, this means taking positive steps to help patient, not just to avoid harms. For examples, we have, you may notice an older adult who become agitated every evening, like sundowning. Instead of ignoring it, you implement the calming strategies like soft music or consistent routine to help the patients feel safe and reduce their distress. The third one is non-maleficence, which means don't harm, avoid causing injury or suffering, whether physically or emotionally or psychologically. The patient with fatigue, with fragile skin for dressing change, you ensure that you use gentle techniques and appropriate material to prevent tearing the skin and avoiding unnecessary pain or trauma. The fourth one is the justice, which is fair and equal treatment in healthcare. This includes fairly distributing resources, time, and attention regardless their age, socioeconomic status, gender, or ethnicity. For example, sometimes you will have one patient with high-profile case and the other with quite elderly woman with no family. Justice means giving both equal attention to ensure their needs are addressed with equity. For rehabilitation and other of the older adult client, we have to stabilize the primary disorder. This means managing the main health issues, like treating stroke with medication and early mobilization to prevent worsening. Also, we have to minimize the impact of comorbidities, which sometimes we need to control other chronic conditions that may affect recovery, like managing diabetes and hypertension in patients having hip fracture. Then we have to prevent disabling like a secondary event, like avoid complications that can be worsening the functions, preventing the bed sources and pneumonias by encouraging mobility and breathing exercises. Then we have to treat the functional deficit by improving the physical or cognitive abilities through therapy, using physiotherapy to restore the balance and walking ability after a fall. Then we have to promote adaptation of the person to the disability, like help an older adult to accept and adjust a new limitation. They're like teaching an older adult with vision loss how to use the magnifier or the voice command devices to read or write, and also to manage their daily tasks, helping them to stay independent as possible despite their visual impairment. Help to adapt to environment. This means modify the surroundings to support independence and safety. Installing grab bars and ramps at homes for someone using a walker. Finally, we have to help carers to adapt to the disabled person. This includes educating and support the caregiver to meet the new care needs, training a family member on how to safely transfer, like for example, a stroke patient from bed to chair. One of the other issues that may affect the older adult is the abuse or neglect. Abuse, it's intentionally or unintentionally mistreatment or harm. This could be physical, psychological, emotional, and sexual, and also financial to other person. Neglect means passive form of abuse, in which caregiver fail to provide for the need of the person under their care. This result of older adult reality. Now we are going to move or highlight the essence of the palliative care. It's a specialized approach that focuses on relieving the symptoms and improving the quality of care for a patient with serious illnesses. It is important to understand that palliative care is not about curing the disease. Instead, it's about making the patient as comfortable and as functional as possible. Palliative care doesn't try to speed up or delay death. It simply supports the person to living well during their remaining time, honoring the life while accepting death as a neutral part of it. We often see competent adults, regardless of their age, to choose to stop aggressive treatment like chemotherapy or dialysis. This decision is deeply personal and often influenced by how the patient weighs the burden of treatment against the potential for quality of life. As a nurse, our role is to support patients and families during this time with empathy, honesty, and also with holistic care, addressing not only the physical but also emotional, spiritual, and social needs. It is important to clarify that choosing the palliative care doesn't mean giving up all the medical treatment. These patients will still receive appropriate care and support their comfort and dignity. For example, if the patient has a wound, we still need to clean and dress it up. And if they break a bone, we still need to place a cast. These treatments focus on the quality of life, not to prolong life at all cost. What many palliative patients do to choose is to decide more aggressive interventions like CPR, artificial ventilation, or feeding tubes, especially if these measures would only extend the dying process without improving the well-being. As a nurse, we shift our focus to what matters most to the patient, relieving pain, perceiving dignity, supporting independence when possible, and providing emotional and spiritual care. The goal is always to help person to live remainder of their life with as much comfort, connections, and meanings as possible. Now we have two terms we can hear in medical fields, like euthanasia and physical assisted suicide. Euthanasia both means termination of life. Euthanasia is physician administer a fatal dose of a suitable drug to a patient. Assisted suicide, the physician supplies a lethal drug, but the patient will administer it. Both are covered by the Act, and in both cases, doctors must fulfill some legislations to meet the criteria. Like every instance of euthanasia or assisted suicide must be reported one of the 5 regional euthanasia review committees. The committees will judge the physicians and has taken due care. And if physician fail to do so, they may be prosecuted, or some penalties vary, but it can be up to 12 years in prison for euthanasia and 3 years in assisted suicide. There is 2 types of euthanasia. There is an active euthanasia and passive. The active that means killing a patient by inactive means. It's sometimes called aggressive euthanasia. The passive euthanasia, it's intentionally letting the patient die without holding any artificial life support, like a ventilation or feeding tubes. This known as don't resuscitate or no CPR or DNR, which we may see at hospitals. Euthanasia, it's in the law in the Islamic and Arab countries, it's criminalized euthanasia. But still, as you can see in the gray color, it's the active euthanasia is illegal, but the passive one is not legislated or not regulated. And the one when in red color, which is means it's illegal, like in Russia. And the dark blue, it's active voluntary euthanasia is legal. We have also the main issues or the other issues that are a common problem in older adult is medication. The factors increase the risk is drug testing methodology, the physiological changes related to aging, the use of multiple medication or the herbal supplement, and also the cognitive and sensory changes in the older adult, knowledge deficit, and financial concerns. There are factors affecting drugs response in the older adult. The first one is the absorption, which caused by reduced liver mass and blood flow. And then we have the metabolism, which is decrease the enzyme and activity in liver. And the third one is disruption or storing of fat-soluble drugs in fatty tissues, decreased serum of albumin for binding of drugs. And the fourth one is the excretion, decrease of renal blood flow, and the filtration rate number, and the number of functional renal tubules available. To overcome this issue, we have to use the CARE acronym for medication assessment. The C is for caution and compliance, to assess the benefit and risk. The second one is adjusting the dose based on the age and condition. We have general rules saying start low and go slow. or a little goes a long way. The R is for the review regime regularly. Polypharmacology is common in older adults, so we need to review regularly the medication that we're going to use. The fourth one is the education. Educate the older adult if the and see if they know of the medication, and also ask the family member to do so. The other issue, the common issues in the older adult is communication. This is due to the sensory changes like a vision, hearing, speech. Also, we have the touch, movement, and cognitive changes. These changes that can be normal changes or pathological changes. It's all impaired the communication and impact that. And we covered that during the semester very well. One of the other issues is the last issues we have is sleep and rest. Common complaints like daytime sleepiness, difficulty falling asleep, like insomnia, frequent arousal during nights. These are the common complaints that we receive at hospitals, and also we have these complaints as a carers. Not only like in hospitalized one. There is a functional consequences like a fatigue, poor cognitive functioning, decreased quality of life, increased depression and anxiety, increased the risk of falls, difficulty of balance and mobility, increased potential move to institutional setting, and increased risk of mortality. We have two common issues. The first one is the excessive daytime sleepiness, and the second one is obstructive sleep apnea, which means the involuntary cessation of airflow for 10 seconds or longer. It occurs because of the muscle responsible to open and relax during a sleep and the passage of airflow.